And thank you for attending, both in person or virtually. A little bit of housekeeping first, if we may. No fire drill this morning is planned. If it should go off continuously, we meet in the Arthur Street car park, Assembly Point C. The meeting is being webcast, and a number of committee members have joined us online. If you're in the chamber, any mobile phone should be switched on to interfere with the webcasting. For those members of the committee who joined by Teams, please ensure that your microphone is muted during the meeting and only switch it on when you're speaking. For members in the committee room, make sure that the microphones, again, are only switched on for speaking, and that they're actually speaking into the microphone. The camera follows the person who's speaking whose microphone is on. We have a number of people joining us today, both from the NHS organisations and the county. I'll introduce them as we get to the item. There are quite a few, particularly for the first item, so I'm not quite sure if they're all here at present, so we'll get to that. Item 1 is apologies. I have apologies from Councillor Barbara Ashworth, Rossendale Council, and Councillor Alex Hilton, Chorley Council, Julie Robinson of Wyre Council. And temporary replacements we have Councillor Enrida Khan replacing County Councillor Mohammed Iqbal, County Councillor Eric Lewis replacing County Councillor Kim Snay. Members declare any pecuniary or non-pecuniary interest.
Chairman, did you say apologies for Councillor Julie Robinson at Wyre? Because I am here. I've managed to get online, like I say, open reach are outside. So if I do go off, apologies, but I am here at the moment. Okay.
Oh right.
Yeah.
Thank you.
Could I just mention, Chair, that Councillor Barbara Ashworth is on Zoom.
He's talking to microphones, which I can't hear you.
Can you see Councillor Barbara Ashworth on the Zoom? I think you gave her apologies, but she's there on the Zoom.
Yes, that's right. I'm here.
Yes.
Thank you, Mr. Chairman. Having taken advice, I'd like to declare non-pecuniary interests in that I am the City Councillor for Donegal Ward, in which one of the extra care facilities is being built, and I work for the University of Cumbria, on whose land the building is being built. Thank you.
That's me.
Probably should declare an interest as a member of the board of Community Gateway when the courtyards was built, and they have another home actually being built at the moment, which is actually in my division. I am no longer on the board of Community Gateway, but I was there when these decisions were made.
And the 16th of November. Are we all happy with those? Are we a seconder? All agreed? Item 4, which is enhanced network model of acute stroke care and rehabilitation Lancashire and South Cumbria, and we have with us today Aaron Cummings.
Thanks, Chair. Chair, is it okay with you if I just introduce the team and the item, if that's okay?
Yes, I'll let you do that.
Perfect. Thank you, Chair. So hello, my name's Aaron Cummins. I'm the Chief Executive Officer at the University Hospitals of Morecambe Bay. But I'm actually here this morning to represent the Integrated Stroke and Neuro Rehab Development Network, which I also chair. And we're going to spend a bit of time with councillors this morning at the Scrutiny Committee just to walk through our business case for enhancing our acute stroke services across Lancashire and South Cumbria. And I've got a couple of colleagues with me this morning, which I'll just in turn just ask them to introduce themselves so colleagues in the chamber and on Teams know who's who. So I'll go with who I can see first. So Kath.
Hi, I'm Catherine Curley. I'm a stroke nurse consultant at East Lancashire Healthcare Trust, but I'm also the clinical director for Lancashire and South Cumbria ISNDN.
Thanks, Catherine. Hayley.
Morning all, I'm Hayley Michelle, Programme Director.
Thanks, Hayley. I've got Elaine.
Hi, I'm Elaine Day and I'm the ISDN Stroke Programme Manager.
Thanks, Elaine. I've got Phil.
Hi, good morning. Phil Woodford. I'm chair of the Stroke and Carers Assurance Group for the ISDN, and for full disclosure, Chair, I'm also an NHS employee. Thank you.
Thanks, Phil. Sharon.
Good morning. My name's Sharon Walkden. I'm a project manager on the stroke programme.
Brilliant, thank you. And Anthony.
Good morning. I'm Anthony Gardner. I'm Director of Planning and Performance at Morecambe Bay Clinical Commissioning Group.
Thanks, Anthony. And I don't think I've missed anyone, but I'm sure colleagues will let me know by text if I have, Chair. So I'm just going to hand over to the team now, Chair, who are going to walk through a presentation. I think Sharon's going to drive the slides, but we'll get through the slides, and then if it's OK, we can take questions at the end.
Okay, thank you.
Sorry, yes, please go ahead on that basis.
Thanks, Chair.
I'm going to present today, and like I said, I'm Catherine Curley. I'm the clinical director for Lancashire and South Cumbria ISNDN. I'm very much a clinician who works on the ground floor. And what this presentation is to present you the business case for enhancement of acute stroke services across Lancashire and South Cumbria. Thanks, Sharon. So the purpose of this presentation is looking at the progress and positive impacts of the project. So we're going to explain the drivers for change to the stroke services and introduce the proposed model of care. It'll be a 15-minute presentation, and also going into the phased investment, which is over 3 years. And at the end, there will be a chance for the committee to discuss with the rest of the team and look at any future implementation of the programme. I'm very conscious now, I am a clinician, so I'll try and explain any, like the clinical words of the treatment that are in the presentation. Thank you. The ISNDN framework does cover all aspects of stroke care across the region. As you can see, we've got prevention, urgent care, acute care, rehabilitation and long-term support. But for the purpose of today and the presentation, we are going to focus on the acute stroke care. Thanks, Sharon. So up to date, we have had several reviews of the stroke services across Lancashire and South Cumbria, going back to 2018, when we were very lucky to have Professor Tony Rudd visit the area, who was the National Clinical Director for Stroke, who set out some challenges for the region to improve the stroke care. All the way through to the national team visit, rehabilitation data, which was quite recent. We are very lucky that GIRFT on there, Get It Right first time. We did have a visit in 2019, again, which set out challenges for us to meet the national guidelines. And Deb Lowe, who's the clinical director, the national clinical director, is one of our regional on the North West Coast consultants. So we do have a really good relationship. Okay. So why do we need to change? What's the case for change? Across our region, we have nearly 6,500 people present to our emergency departments in Lancashire and South Cumbria with stroke symptoms. Now, what probably surprises a lot of people is we do have quite a high mimic rate, and we prefer to actually see these mimics to rule out a stroke rather than miss a stroke. So we see that as a part of our care. So when you look at stroke figures, that isn't the amount of patients that we see, and we're actually seeing everybody, including the mimics. There were 2,500 patients admitted who were actually diagnosed as acute stroke, and there were 442 deaths due to this. And as you can see, we do have, like I said, there was over 6,500 people presented, so that's over 4,000 people with stroke mimics. And what we found that there are two things. You've got an acute stroke unit nationally and a hyperacute stroke unit. Now, hyperacute stroke units is a higher level of care, much more intensity, giving much more intense treatment. We've only got acute stroke units in our hospitals across the region, and our aim is to have hyperacute stroke units. Nationally, I'll explain what thrombolysis and thrombectomy is. Nationally, our thrombolysis rates are 15%, but in our region it's only 8.9%. Now, thrombolysis is when a patient has a stroke, which is the most common one caused by a blood clot, and it's a clot busting treatment, but you can only give the treatment within 4.5 hours. And 1 in 3 people make a complete recovery from the stroke, 1 in 3 some recovery, and 1 in 3 none. So you can imagine what life changes that can make for people. Thrombectomy rates are only 2%. We're well below the national ambition of 10%. Again, what that is, you go in through the groin, send a catheter up to the brain and remove the clot. That's the most simple way I can explain it. Our length of stay is quite high as well, 25 days through the discharge, but a lot of people that have had this comprehensive stroke model, which we're presenting today, have a much smaller length of stay, 16 days to 17 days in Manchester and London. We also have significant shortfall in the region of the appropriate staffing to implement this project. Thanks, Sharon. Oh, my slide's not moved on. I don't know if it's moved on everywhere else, but my slide's not moved on.
No, it's not for me either, Kath. Just bear with me. I'm pressing.
It's okay. But just to mention, one of the key things, obviously Phil's here as well at the minute, is that it's about the patient experience. Everything we're doing is about the patient experience. It's not just about national guidelines are evidence-based, absolutely, but we've got to make sure the experience is reflective of what our patients need. So this model will give equity to all our patients across the region, looking at reducing long-term disabilities and deaths, and it will save costs to the health economy. So what we're proposing is that we have 3 acute hyperacute stroke units offering 24-hour-day specialist care 7 days a week. Now, these hospitals will be Preston, Blackburn and Blackpool. They will be repatriated back to their home site if it's not one of them hospitals, which is a home site, within 72 hours. So that is repatriation to Furness and Lancaster. And what the ambition is, at them hospital sites, you'll have somebody meeting the patient at the door, an expert in stroke 24 hours a day, 7 days a week. We'll have an ambulatory care pathway, which I'll explain a little bit later on. And our inpatient strokes will have 7-day rehabilitation back on all their own sites. This will involve 2 things. First of all, if a patient presents to Furness General Hospital, they will still be met by a stroke team. And if they're in acute stroke, they will then be transferred to Preston for their acute care. If it's a Lancaster patient, there'll be a direct divert straight to Preston. And appropriate ambulance cover for patients to be repatriated is something that we're looking at. And we'll have integrated community support as well. Okay. So the proposed model of care, I'm not going to go through all the figures, but as I said earlier, you can see the amount of A&E presentations we do have, and 6,500 in total, just over 2,500 are confirmed strokes and 3,800 are stroke mimics. But like I said, we've got to take that into consideration for the whole reconfiguration of the stroke services. Thanks, Sharon. So the next one is the impact of the model of care. Can we just say that no stroke unit is closing? We're just reconfiguring where different aspects of the care takes place. The emergency department will be strengthened by the right amount of staff, making sure the patients get the right treatment in the right place. And we will have a strengthened ambulatory model. I'll just quickly explain what that is. We aim for 7 days a week, 8 in the morning to late at night. Any patient who comes into A&E who is a very minor stroke that isn't severe, or high-risk TIAs, that we do the diagnostics, the scans, diagnosis and treatment, and we can send them back home the same day with therapy support in their own home. And just to give you a quick example, we've been doing this in Blackburn for the last year, but we collected some figures over the last 6 months, taking into account we only do Monday to Friday currently, and we've had sickness to cover, so we've not been doing it as we would like to. We've actually seen 140 patients, and we've actually saved 70 admissions to the stroke unit, and 70 patients did not have to come back on another day to a TIA clinic. We did everything, which is a real benefit to the patient's journey. So the treatment will be standardised across the region, so there'll be no variation, and there'll be reduced stroke deaths and disability. And our community, because what a lot of our patients said and carers, that once they left hospital previously, they felt like they'd been left. So that's one of the key parts to this project. Okay, thanks. So the impact of the proposed model of care, increased stroke service staffing. So the establishment of staffing on each site will be strengthened to make sure that all our patients do get the correct care. The patient flow will be much better, and it will be patient focused depending on their need. And like I just said, the community team is strengthened. There is an impact on the ambulance service. There's going to be obviously a number of transfers to different sites and back, but that is being looked into, and I'm sure if you want to ask some questions on that later, you can get some answers. But also Preston, with it being the actual comprehensive stroke centre, there will be an increased number of patients presenting there, and that will be quite a big impact. Thanks, Sharon. So benefits of proposed change. We can save 22 more lives per year across Lancashire and South Cumbria, and a 5% mortality reduction. Improved clinical outcomes. As you can see, like I said, we're actually low on our thrombolysis rates, and the impact, if 1 in 3 make a complete recovery, 1 in 3 make some. If we can increase that to 8 to 15%, that will be massive, and increase our thrombectomy rate to 10% from 2%. And 361 more patients will be discharged with reduced disability and dependency, and 1 in 5 will achieve full functioning independence following thrombectomy. And improved quality feedback. I mean, our patients are just over the moon with the ambulatory model, especially during COVID, when a lot of people didn't want to stay in hospital. And there'll be a reduced cost to the NHS and social services. Okay. So carer impact. Phil's group, which he was mentioning earlier, the patient and care assurance group, we've discussed lots with them. One of the main things they wanted, if a relative was being put in the back of an ambulance urgently to another hospital, Preston, they wanted to know where they're going, what's the postcode, where they can park, are there any local hotels, how we can get hold of my relative and know where they're up to. So we've produced a leaflet through these groups, and it's now out there for circulation. Plus, they wanted to receive information on communication all across the pathway, because it's a very, very scary thing. Thanks, Sharon. So travel times to Preston Comprehensive Stroke Centre. As you can see, the furthest, because this is obviously if obviously we're doing direct divert and treat and transfer, the furthest is 1 hour and 4 minutes. And the least is Garstang, 22 minutes, but this isn't with blue lights. This is just as you or I would drive to them hospitals. Thanks, Sharon. So the phased investment plan is over 3 years. The first one being the last financial year, which we're just coming to the end of. And the main thing was to actually try and strengthen the ambulatory model with estates at Blackpool. The other main aspect is to strengthen Preston's beds for the thrombectomy service, because we needed to increase beds to receive these patients. So next financial year, recruit nurses to actually meet patients at the front door to make sure that they're signposted and treated in the correct way. The other quite exciting thing of the next financial year is to actually recruit staff, including nurse consultants like myself, on all sites. So the ambulatory model I was mentioning earlier, we can run 7 days a week, 8 in the morning to late at night, which will make quite a big impact. And obviously we've got to look at these estates. Now, the financial year 23 to 24, there is a lot around estates, there's a lot around staffing, and there's a lot around supporting the 7-day rehabilitation service, because people don't stop being ill and needing support Monday, at a weekend. Obviously there is an issue around MWAS, so they've got to support that and enhance that care as well. Okay, thanks, Sharon. So the year's progress to date, the build has started on the ambulatory unit at Blackpool, Victoria. So they can see them in a day and discharge them home. The recruitment process has commenced in the emergency department with specialist staffing already. Like I said, we do this project at the Royal Blackburn Hospital, and recruitment is taking place at Preston as we speak, so that we can look at offering in a phased approach 7-day thrombectomy service, because at the minute it's Monday to Friday 8 till 6 with the last person on the bed at 4:30. Following that, the year after, we are actually looking at expanding that 24/7, and there's been significant improvements made in rehabilitation across the patch. Without having their community teams, we wouldn't be able to discharge them earlier, and they won't get the support in the community. Okay, thanks. So assuring the preferred option, we have had lots of assurance groups. The most important one to me is Phil's group with the patients and carer. But we have had the ISNDM board, which is the most recent one in March 21. We've had financial advisory groups, we've had provider collaboratives, and we've obviously had strategic commissioning committees as well. I think we're on. So the engagement to date. So we've had, like, obviously our local survivors, and I'm not going to go through all of them, but you can see how much engagement we have had to date. Okay, questions and feedback for any of us? Thanks.
Thanks, Catherine. Chair, any questions? I'll ask Hayley, as the programme director, just to direct any questions that come through. We'll make sure the right colleague gets the right question.
Yeah, thank you, Chairman, and thank you for the presentation. It was very clear. This question sounds aggressive, but it isn't. Looking at the report, we failed to achieve the national average levels on a number of areas across Lancashire. You're now asking for another £14 million in revenue, almost £6 million in capital. In spending that money, what lessons are being learned to date so that we can avoid not being at national average? So that there must have been quite a lot of care and attention to the stroke service. What have we learned from not being at the national level? Obviously, one of the simplest things, I presume, is 24-hour care 7 days a week. But it's just, is there anything we can learn from that, or is that just circumstances? Because I know it's a diverse population in Lancashire, but deprivation levels would be the same in theory, averaged out across other ambulance NHS services. So is there anything we've learned from that that we can make sure we don't spend 14 million and not improve?
Yeah, very much so. So I think I'll come to Catherine first to offer a clinical perspective in response to the case for change, and then Elaine following on from that, if that's okay.
Yeah, no problem. One of the things for us is that Manchester and London adopted this model quite a few years ago, and the lessons that we have learned, and we do something called SNAP, and that's our national data, which every stroke service in the country is recorded in every single thing that we do. And a couple of the key things that came from that was, if you go to a specialist centre, all your staff become experts. If you've got a smaller amount of patients coming through, your staff are less expert, should I say, even though you're trained in that area. So you do thrombolyse more, you do more thrombectomies. You're a bit braver, you look at the evidence more, and it is set up to work like that. Now, the other key thing that we've learned, not just from London, from ourselves, is the sites that haven't got a team to meet the patient at the front door. We get a call from the ambulance or a call from A&E if somebody self-presents, or if a patient has a stroke on the ward. Is that team 24/7 going to that patient straight away, ordering the scan, recognising what the urgency is, because we've only got a very short period of time, and recognising what the next step is and who's the next person we need to contact, what diagnostics. I think clinically they're the keys, Hayley, for us.
Yeah, super, thank you. Elaine, do you have anything to add? And then perhaps we can offer Phil an opportunity to come in from a patient perspective as well.
Sure, sure. I suppose for us as well, we had the other lessons learned from Manchester and London, and it was what if they were doing it again, what would they do differently? And we took that advice, and they said straight away, we would look at our back doors first. We would absolutely resource our community team. So we took that as a priority, and we have had successful business cases across the ICPs within Lancs and South Cumbria for each of the community stroke teams. So those are all in slightly different progress, and you could sort of see on the slides that that was one of the things that has improved already. And that's what we had investment in. And obviously the other element, I can absolutely understand, you know, the councillors' concerns about the fact that we've been working it a while and things hadn't improved, but a lot of that was done with no resource, and we did as much as we could without resource, waiting for the business case to move on to the next stage. So I think that's my bit to share, Hayley.
Thank you. Phil, would you mind just commenting on what that means in real life, perhaps, in terms of the risk escalation and any learning that we've developed?
Absolutely. Thanks, Hayley. Yeah, I think it's a great question, Chair, from the councillor. I think it's important that we learn the lessons and don't repeat any mistakes of the past. Stroke's still the 4th leading cause of death in this country, and the leading cause of disability. And in this area, I think a key lesson to learn is that we see between 20 and 30 people, so that's 20 to 30 of your constituents, die unnecessarily each year. And in terms of the lessons learned from that, that's because of access to the care and the parity of care. Kath talked about Professor Rudd earlier, and it's Professor Rudd's work, which is why we were lucky to have him, which is shown you need to be in the right place at the right time to receive this care. And as somebody who's had 2 strokes, you know, why listen to me? Well, unfortunately, a third of people who have had strokes are going to go on to have another stroke. You know, I'm tomorrow's customer. And what we'd like to see, and what we're seeing now, is we spend a relatively short amount of time in hospital as survivors. It's in the community. You know, we want to spend the rest of our life there at whatever age we are. But the treatments which Kath's talking about, and I think that's learning the lessons certainly around thrombectomy, is I've got to be a realist as the rest of the group is around this. We'd like that provision at every single hospital, but the realism is there isn't that many trained staff in the country to have it at every hospital. They don't exist, and we can't wait for them to be trained up, because that's the situation right across Europe and further afield. But this treatment means that nobody's disadvantaged because of age or ability. You know, whether you're 75 or 80, this isn't 30 years ago where you were written off, where you have a stroke, or whether you're 18 and you come into hospital. People are walking home the following day in a lot of cases. It's that parity of access as survivors and carers we want to see, and that's what we believe this bid gives us. Thanks, Chair.
Councillor Mean.
Thanks, Chair. Yeah, the previous speaker just touched on it slightly, but the success of this project is going to have to rely very heavily on having the right staff in the right place at the right times, and being able to offer a 24/7 service is going to prove rather challenging, I would have thought. We're all aware that we already have a shortfall of about 5,000 nurses in this area. How confident are you that you'll be able to recruit the right staff, and what are you putting in place to ensure that the staff are being trained up in the areas that you wish to see them?
Thank you for the question. Elaine, I'm going to come to you first, if that's okay, followed by Catherine.
So one of the things that was highlighted when we first started this was around the shortfall of workforce and what we were going to do. So the investment plan is a 3-year investment plan, and we have a 3-year workforce plan that sits alongside this. We're working with our local universities to set up different courses for us along the pathway. So, for example, we're really short on speech and language, but to actually get a speech and language therapist, we have to go to Manchester or Liverpool, who deliver those courses. And of course, it's quite a little niche market, stroke speech and language, so it's not easy always to get them, and they're not in massive amounts nationally. So we know it's a national problem, not just that, but UCLan have now put on their very first speech and language course. They've also set up a new dietetics course. We are concentrating in our AHPs on assistant practitioners, so they've set us up a course that is a bespoke course aimed at stroke and neuro rehabilitation, specifically for assistant practitioners. We have made sure that the input of money that's coming is around, hopefully, when the courses are available, so we can recruit onto each of the courses. So at this minute in time, we've just recruited to the assistant practitioner course, to the SLT course, and to occupational course in Sheffield for our therapists there. From a nursing perspective, we know that assistant nurses as well is going to be high on the agenda. So we're going to be concentrating on those level, but also on those clinical leadership elements that Kath talked about, like for ambulatory care, but also for advanced practitioners. And what we are confident, we to be honest, our sites mainly, I know we talk about a shortfall, but our stroke units are considered to be quite good places to work. So actually the recruitment to them is good. It's just that it pulls it from other staff within the hospital as well. So we're conscious that when we do that, it's not just the stroke unit that impacts, it's the rest of the hospital if we're moving staff. So we are relatively confident that we can do that.
Thank you, Elaine. So in summary, we're looking at sufficient training, introducing new and blended roles, and most importantly, future-proofing our services and succession planning in terms of the really good staff that we already do have and retaining those on the ground. In terms of the practicalities of that then, Kath, is there anything more to add?
Yeah, Elaine did mention, but we're very inventive with our staffing, and I'm going to champion nurse consultants because I am one. And just to give you an example, 5 years ago, Blackburn was a D on what we call SNAP, we're now an A. And that's due to a lot of things, and that's being inventive. There is a national shortage of physicians anyway. So they've recruited nurse consultants. Also, we're looking at band 4s to do other roles that are a bit more advanced in a care assistant, but not quite a qualified nurse, like, but you can give like peg feeding, ECGs. So you work together as a team. And one of the other aspects is, like Elaine said, when we become a hyperacute stroke unit, that's up there with the same class as a coronary care unit, which is always an attractive area to work in, and it's so diverse. So people are actually coming. We've currently on our stroke unit and the others, I've got more people wanting a job than we've got vacancies, and I know that's highly unusual at the minute, and we're not naive, that could change, but it is because we're supporting advanced practice, which is good career progression. And it's so varied from A&E to rehabilitation to acute units, the skills that you learn and the difference you make. We're also not naive. One of the biggest challenges we've got is the interventionalists, I know Phil touched on it, who actually do the procedure of thrombectomy. It is a national issue, and we're not the only ones who are struggling to recruit, but that is a challenge. And nationally, they are looking at training stroke physicians, and cardiologists go into major vessels to remove clots. So they are looking at inventive ways across the patch nationally. Thanks.
Thank you, Kath. I'm just going to invite Sharon to join the conversation.
Thanks, Hayley. It was just to add that digital does have its place, and whilst it doesn't obviously replace people or the human touch by any means, last year the introduction of artificial intelligence for stroke and brainomics just supports people and help people to do the jobs more effectively. So even if they aren't on the site, they've still got access to brain scans and results of assessments, and they can make decisions as if they were in the room. The therapy teams are also looking at creating videos to help support people with the conditions, and the carers as well. So again, they perhaps don't need to have that person in the room with them. There's other ways of accessing information and treatment.
Thank you, Sharon. I hope that efficiently answers the question, Chair.
Yes, thank you. Councillor Haythorne.
Thank you. My question is, in the case for change, you refer to staffing levels falling short of the initially recommended levels. I'm just wondering, in my travels around the patch, I find that some NHS workers are disillusioned by the amount of change that goes on. I don't like to see that, of course, and I defend it rigorously, but just the same, it does seem to be happening. I'm just wondering if you feel that these changes will leave some people behind, and that the things that they have been doing, they won't be doing any longer. And I'm just wondering whether that's likely to affect them. Are you worried at all about losing more staff from the people who may be left behind? specialist services having left and from elsewhere?
Thank you for the question. I think this is a typical theme that we're seeing throughout all clinical redesign work at the moment, unfortunately. So I think I might come to Kath first to offer the clinical perspective and then to Elaine.
Yeah, no problem. This was something we were concerned about. So last year, what we started to do was go and visit each individual hospital as a team with Elaine to talk to staff, get the thoughts and feelings of all the staff. So following that, we've actually had some workshops of what to work towards. Now, what we had to get across was, like we say, nobody's losing the stroke unit, we're just strengthening it. So for example, Lancaster, because that's going to be direct divert, is the one that you would think would cause more concern and disillusionment for the staff. But what we are doing there is, again, we're actually developing the ambulatory model. They will still have an acute stroke unit to go back to. We're strengthening that acute stroke unit to make sure the patient gets the best care. And we're actually supporting staff to be trained and develop the ambulatory model and become more independent. So, like I said earlier, we're not being naive. We're not saying that'll suit everybody, but we are strengthening that team. So every other site, obviously the comprehensive and primary stroke centres are the ones where most of the patients are going. That's more enticing. But also we're strengthening Barrow in Furness because we need them staff at the front door before we treat and transfer. Another nurse consultant's already been employed there, and there is other advanced practitioners who are in training. So yeah, it hasn't been all smooth, but now we understand what people's needs are, and we have actually explained to them that this is good for the staff there. It is good development for their progression. They seem happier, and I think Elaine will probably add to that.
Yeah, absolutely. So I think the case for change summarises that perfectly. And of course, staff have contributed to that case for change themselves, and also the response in terms of the model of care. So there's no surprises with that model of care. I think everyone sort of knew that things were going to be stretched. Unfortunately, that is the way that things are working at the moment. And I think that there is some aspirations to look at how we go about that in a different way, as we've touched on earlier. So there's no surprises within the model of care. I think it is realistic, but aspirational at the same time. So Elaine's just going to build and touch on that a bit more.
So, as Cass said, this it's not a surprise for anybody. Prior to the workshops that we did last year, which was post-pandemic, coming into this year, we'd actually had workshops at each of the hospitals with the operational managers, with the staff within the wards, with the therapy staff. We have work streams as part of our ISDN where we meet regularly and we talk to the leads from the teams and we talk to the people on the ground floor. We hold many regional workshops because we write regional policies together. We work as a collaborative across the patch. So many of our teams all know each other and they all work collaboratively and they all share collaboratively. So I feel that their knowledge and input is filtered down to the rest of the staff as well that don't attend these meetings. So I don't really know how much more we can do in relation to building on those staff things. We do a lot.
Thank you. County Councillor Lewis.
Thank you, Mr. Chairman. Good morning, everybody, and thank you very much for the presentation. I was wondering if you could speak to a couple of different issues. We've heard quite a lot about the consultation, but I don't think I've heard any reflections offered from trade unions or the professional representative bodies of the staff that are involved in this, in these changes, and I'd be interested to hear those views. I couldn't see the bottom of the slide when you were putting up travel times from Lancaster and Morecambe because it disappeared behind the chairman's chair. But I did notice that Ambleside was clocked in at 1 hour and 4 minutes, which if you've ever done that run during summer, you would know was highly ambitious. And I guess it is one of the things that often comes up so I'm a Lancaster-based councillor. I guess it's a thing that often comes up in discussion about healthcare in North Lancashire or South Cumbria and North Lancashire, is the centrality of the M6 and how if that if something bad happens on the M6, then actually the M6 blocks up, the A6 blocks up, and it can actually take hours and hours to get from Lancaster to Preston, let alone Ambleside to Preston. So those travel times seem, I guess, hopeful. And in that moment where stroke response is very acute in terms of timeliness, I wonder what the backup plans for that. And of course, we're looking at the new hospitals program and the impacts that that might have. And I realise that we don't want to wait until everything, like for the new hospitals program, because that's a long process. But how would these changes fit into the thinking that's going on around those projects? Thank you.
Thank you. So firstly, with regards to trade unions, I'm going to come to Elaine, who can summarise the engagement to date, supported by Sharon.
So from a trade union perspective, we haven't really had any dealings with them, and that's because our staff seem to be happy. They seem to be there. We've not invited them to any of the meetings per se. If staff were unhappy, they would have gone there further. Sharon, I don't know if there's anything else you were thinking about in regard to that. Obviously, we have done quite a lot of engagement across the patch.
Yeah, but take the point, and I know there is a forum where there is representation from staff side and trade unions, so we can certainly attend and, you know, say this is what we're doing, this is the engagement we've had so far, and the engagement with staff, and get their views on it and put it on their horizons, so we can take an action to do that.
Yeah, thank you. So with regards to the second part of the question relating to Ambleside and the travel times, I'm going to come to Kath first of all, supported by Elaine, and then Phil can come in from a patient perspective.
Yeah, I mean, obviously I'm going to focus on the actual acute side of the care rather than, you know, the travel, but because of the delays. Furness General, the patients will still be going there for the thrombolysis and then being transferred for thrombectomy, and the differences with which is what they've always done. The difference with this is they'll be getting the acute care at Preston instead of Furness. Now that we're actually strengthening the front end, they should get their thrombolysis and their assessment for thrombectomy far more efficiently and quicker. So that will be of benefit to the patient. They've always been transferred for thrombectomy to Preston, but strengthening the front door will assess patients much quicker and hopefully get more patients there that are suitable. The acute care will be given at Preston, so the care shouldn't be compromised there. Direct divert from Lancaster, which is much closer to Preston than Barrow-in-Furness. With our SNAP reports, nationally there were some challenges at Lancaster with getting the scans and the pathways at the front door. So this was one of the reasons that we are transferring direct divert to Preston. So hopefully the plan will be that because of this focused pathway, they will still get the scans done quicker because you've got that focused team at the front door, and they are actually in the centre that does the thrombectomy. So instead of going via Lancaster, they are actually in the centre that does the thrombectomy, and we've got the neurosurgeons on site. So if it does turn out to be a hemorrhage, they won't then have to be transferred, so more lives will be saved. Okay, Elaine?
Yeah, just to say that obviously we're working very closely with NWAS in regards to this model of care that we've got. We're doing further modelling with them at this minute in time. We obviously put some finance into the business case to fund NWAS. So we're just ongoing modelling at this minute in time with them. Sharon, did you want to come in there? Did you have anything you wanted to add?
Just in relation to that, I know this isn't a catch-all solution for any kind of critical incidents and blockages on the M6 and A6, but a number of stroke survivors have had the opportunity to use the air ambulance, and again they've spoke so highly of the experience of being able to get to the hospital within time. I know that's not a 24-hour, 24/7 service, and there are conditions where it can't fly, but it's definitely been used in cases where there's been issues with the roads.
Thank you, Sharon. I'll come to Phil.
Yeah, thanks. I think Kath and Sharon have summed it up really well. I certainly know of two from Cumbria or South Cumbria thrombectomy patients that were flown by helicopter and had a great outcome as part of the Headway charity group. I think they've said everything, but from a patient perspective and from survivors I've spoken to, being blunt, we want to go to the place that's got the right care. And if I was in Ambleside, I'd want to go to Furness General first to be stabilised and then transferred to the right place, which would be Preston for the thrombectomy, because it's not available everywhere. And we're also talking of in this bid that Preston, with its rating of care, it gets a bit lost sometimes in terms of, someone mentioned SNAP data before. So all the stroke units are rated A to E. A is the best. E, well, it speaks for itself. The better you get, the facts are less people die and less people have lifelong disability in the better rated units. So this is about getting you to that best rated unit, not because the others are bad, but this is because these have got the additional resources that can give you the focused care. So speaking to patients, having gone out with the Stroke Association and speaking to the members of the public, they understand that proposition and want to go to the right place. It can seem counterintuitive that you're driving past your nearest hospital, but you want to go. It's the same now with cardiac. You know, I'd want to be taken to Blackpool if I had a cardiac problem. It's not because I don't trust the hospital where I work at. It's just that that's where the specialists are that see this problem every day, and that's what I want. Same in maternity. You want to go where the numbers are. You don't want to be the first time they've seen a complication, and it's no different for stroke.
Thank you, Phil.
Thanks, Hayley.
Thank you. Lizzie, have you got a question before we go on to the third part, perhaps?
Was more to come in the answer?
There was more to come in the answer in regards to the new hospitals programme, just the third component, but I think Lizzie's got her hand up actually. Would you like me to finish, or shall I go to Lizzie?
I've got two more questions. I've got Councillor Carr, County Councillor Carr, and then County Councillor College. And then I think we'll move on to the next stage when we have our discussion and make recommendations on the way forward. So County Councillor Carr, question.
Thank you, Chair. Just on the equality impact assessment, I know you've not spoken about it today in your presentation, but it says that there's a higher risk amongst the BME community and male and the gender. Do you have any data for the different areas as what percentage of those particular groups from the different areas that, you know, we have? Do you have anything on that?
Yeah, we've got a
what
whole.
is your link on the preventative work that, because I'm looking at the benefits proposed enhanced stroke and network model, but there's nothing in there that says that you're going to be working with the BCFS sector or this preventative to work with those particular groups.
Thank you. I'll come to Elaine first, and Sharon, do contribute if there is anything with regards to the data, and we'll see how we go.
So we do have data. I don't have it at my fingertips right now, but I can forward it on to you if you need that data. So which is around where we're going. Obviously, in relation to our BME communities, it's higher in Blackburn with Darwin, Blackburn, Preston areas, and we do a lot of stroke awareness raising, but unfortunately, as part of our groups, we are quite low on the ground from our other ethnicities that attend these meetings, but we do go and talk to these groups. I can share the data with you that's been devised basically, but it's high level fingertip data from public health.
Thank you. Sharon, is there anything to add?
Yeah, so you mentioned the preventative aspect. So there are a number of projects that are up and running this year. One of them is around supporting people to self-monitor. So, for example, getting blood pressures into homes, and they're run by GP practices, and there will be GP practices in those areas that perhaps do have higher level of BME communities or higher levels of deprivation. So that's one way into those communities. There's also a project about identifying people who might be at risk of stroke if they're admitted to hospital for any reason, not because they've had a stroke or a cardiovascular episode, but about picking up those when they're in the emergency department and triage, and again being able to get them on the appropriate pathway. One of the benefits of the work is to make sure that there is no variation, that everybody has the same kind of treatment no matter what area they come from. So that'll be another way of ensuring that no matter what locality or community, they'll always have the same quality, high quality service. And as a patient care assurance group, we're doing quite a bit of work at the moment about trying to increase the diversity of the membership and to make sure that it is representative of the communities and also the different conditions as well. So we are making, we met with some faith leaders recently. We're also trying to work with Pendle Community Radio to get messages out that way. And if you've got any other suggestions for reaching those communities, they'd be grateful received as well.
Thank you for those answers. County Councillor Collins.
Thank you, Chair. So first of all, I really would like the answer that you weren't able to quite get to, Hayley, about the new hospitals programme. And then secondly, I think Councillor Lewis's question about travel times hasn't been fully answered. So I think we'd like to know, what is the plan if the M6 is shut? Is the plan that it's blue lighted down the A6? Is it that the air ambulance is there? I think we want to know, very practically speaking, what are your plans? Because I think Councillor Lewis is right in that some of those travel times are very ambitious, certainly in summer and from the more remote areas. And finally, I'd just like to say I have the advantage over some of the other members of the committee in that I've already scrutinised this at the steering group and I've had my questions answered very well, many of which match what the rest of the committee have been asking. And I have to say, I find the clinical case irrefutable. And on the condition that the concerns raised are addressed as far as possible, I am supportive of this case for change. But we might well get onto that discussion later. Thank you, Chair.
Thank you. So I'll come to Aaron, if that's okay, for the new hospital programme first, and then to Kath to elaborate further on travel times.
Thanks, Hayley. Yeah, and thanks, Lizzie, for the reminder of picking up. So the new hospitals programme, colleagues will be aware, it's a fantastic opportunity for us to get some much needed investment and improvement into hospital facilities, in particular in our region. And it's quite a lengthy process. I think the council that asked the question previously recognised kind of the complexity of making decisions on improvements and transformation when there's a potential for something to change in the future. What I would say is we're still at an early stage of the new hospitals programme development in terms of going from long list of options to short lists of options. But the current way that the new hospitals programme is overseen by the ICS board and through respective boards means there's a natural alignment to the progression of transformation improvement now as we're building for the future. So there's some assurance that for those clinical models that are changing based on best practice and national guidelines, there will not be a rowing back when the new hospitals programme development progresses to say, well, that's, that was then and we want to do something different now. That is evidence based, it's clinically led, like Councillor Collins just said, that the clinical case in particular is very, very strong. So any change in facilities or investment, this is the model of care. This is the way that kind of strokes will be managed and kind of clinically that the service will be delivered alongside that. So the two hospitals that are in kind of the new hospitals programme purview, the Royal Lancaster Infirmary and Lancashire Teaching Hospitals, the Preston site in particular, that is a cognizant piece of clinical design work that we know that the stroke pathways are set, and that is the pathway that will be included in any developments if they're successful.
Thank you. So the second part of the question relates to travel time, so I'll just come to Kath to elaborate further on that quickly.
Yeah, no problem. As Councillor Collins said, he was happy with the clinical answer to that question. I think it is what we would actually do if the motorway is shut, and I don't know the answer to that. Now, unless Elaine knows the answer to that, that is something that we can look into with MWAS. What is their contingency? And if the answer to that contingency isn't suitable for us, we will have to look at a contingency. So, Elaine, unless you've got an answer to that, I'm grateful for that comment, because that's a contingency we need to consider, which Elaine may have already considered.
I think Anthony wants to come in a little bit before that, because I think it might be his remit.
Yeah, thanks. So apologies, I don't have a definitive answer, because in a way there isn't a definitive answer. As colleagues have said, it will really depend on individual circumstances at the time. This was a really important issue for us, as you can imagine, councillors, as clinical commissioning groups, particularly as both of you have said, for the population that's at the top end of South Lakes, where travel times are really, really difficult, and we get that. As you say, in summer it's very congested, very difficult. In winter it can be difficult with weather conditions and road access and so on. And that was why when the Joint Committee of Clinical Commissioning Groups considered the business case, they did ask for further work to be done with NWAS around the travel times and around the access points, so to start to do some of this scenario planning that's been talked about on the kind of what if the accident is here and you can't get out, what if the road is blocked there and you can't get out. There are obviously a number of different options depending on where you are at the top end of the lakes. Not only to divert down the A6 if it's the M6 or vice versa, maybe to divert across to Furness General for treat and transfer, even the air ambulance has been mentioned, and even the possibility of going north on rare exceptional cases to Carlisle and blue light up the M6 north to Carlisle. Clearly NWAS as the ambulance experts are the right people to look at this, because they've got the technical mapping software. They know through vast experience what the key issues are in different parts of the lakes around that, and that's why we asked them to do further work with the group to model this through, to think about it, and to come back with some of the issues that we need to be aware of. So we don't have the perfect answer on this, but as Elaine and colleagues have said, we're working closely with NWAS to make sure that this is done. We've got a couple of years before the big parts of the change start to impact on that population for South Lakes, when the comprehensive stroke unit starts to come on stream. So we've got the time to do this, but clearly we're not wanting to rest on our laurels and kick that too far down the road. We need to start doing that when that work is ongoing now with NWAS, to make sure that we can build in the contingencies as early as possible.
Okay, thank you.
Thank you, that's great. One last question from Councillor Pope.
Thank you, Chair. I've been also looking at the Mersey and South Lancashire stroke services, and they've recognised very early on that the key factor is transport. They've basically working on a 6-hour journey to get people to have thrombolysis, thrombolytic treatment. And they've actually, we had a presentation last week, and they had somebody from the ambulance service there from Cheshire and Merseyside. Now, you know, whilst he was very good and had identified the additional resources they needed, it didn't actually cover South Lancashire, the West Lancs area that I represent. And I can understand Councillor Collins raising the issue from the north of the county and South Cumbria. This is a major issue, and it's been recognised by the Mersey team. The key, if you look at the statistics from Manchester and from London, SNAP reports from there, clearly getting people to the thrombolysis and thrombolytic treatment as quickly as possible is key. Yet we don't appear to have allocated any budget here to NWAS. So I have great concerns about that, and I think considerable work needs to go into that. The other area I have concerns about, you know, if we look at the gap analysis, I think in terms of the staffing, page 27 of the report, you've basically got about 70 positions that are not filled within the OT, physio, psychology, dietitians, etc. And I just wonder, we have 4 universities in the Northwest. Basically, you've got Edgehill, you've got UCLan, you've got Lancaster, you've got Cumbria. And how many programmes have been set up with those 4 universities? I think it's been proven from the dental perspective that UCLan set up a dental course a number of years ago with outsourced dental education centres. And a lot of the staff have actually stayed in those areas. And I think with a lot of these other staff, if they're trained in the area, they quite often stay in the area. And I wonder what work has been done to actually facilitate that going forward. Thank you.
Thank you.
If I may just come in there, I think on travel time, we've asked the question twice. We may not be satisfied, so I'm not sure we need to ask that one again at this stage. Brilliant. Well, right. If anybody can add to what's been said previously by way of an answer on travel time, and then the other aspect about staffing.
I don't think we could probably elaborate on that any further, to be honest, but happy to take further considerations outside of the room. It could be that we pick up the second part first then, in terms of gap analysis and our relationships with universities, in which case I'll come to Elaine first, if that's okay.
Yeah, so we already mentioned that we're working with the UCLan in particular, because the UCLan, we obviously have got universities in Manchester and in Liverpool that do therapy courses, and obviously, as pointed out, if it's done locally, you might be tended to keep things locally. So we've actually started therapy courses at UCLan this last year. So we've worked very closely with them. We've also worked closely with them around assistant practitioner courses, etc., and assistant nursing courses. We are working on a phased approach, because we know that we've got a massive amount of staff that we need to bring in, so that we're as a region, we're working together. So we're putting staff on from each site, each acute site, onto each of the courses to upskill some of those staff. We've also recruited apprentices into the apprenticeship roles for OT therapy and speech and language therapy and dietetics. So we've recruited from each of those sites at this minute in time. We're concentrating on the leadership element of the nursing. So we're looking at advanced practitioners and consultant nurse practitioners, and we're doing quite a bit of work on upskilling those. We've got, I think it's 5 consultant nurses now as a region across the patch, which is, you know, it's a massive move for us in the last couple of years that we've been able to manage this, and we've moved our services on because of those posts. And just a very quick one, just to flip back, we to the MWAS question, we do actually have funds that are available in the business case for MWAS. So I can assure that councillor that we have thought about it, but we have further modelling to do and may need further funding. So just to put his mind at rest there.
Sharon, do you want to just add the final point?
Just on the workforce and the collaboration with unis, we've also secured some funding for a regional role to support speech and language therapy training. So that's another way to tackle that. And we're working with Edge Hill University on carers assessments as well. So just another way to work collaboratively with the local education establishments.
Thank you for that. I think we'll move on to the next stage now. But 2 things to consider. One is whether we think whether we're happy with the proposed changes, and whether we think it's a substantial variation. Quite a lot of information there. The only really concerns we've come out with are the travelling time, particularly for the Cumbria part, I think, of the area. Is there any concerns about the proposed changes that you want to voice now? Yes.
I'm just concerned about, we're saying Preston's going to be the new hub. What happens to Blackpool, which is the current cardiac centre at the moment? So is that going to be diluted, or is that going to be enhanced in terms of stroke victims? Just wanted to see how that works. And are these hospitals you mentioned, is it that they're going to become centres of excellence once you sort out the staffing that you've got?
Thank you. I'll come to Kath if that's okay to respond, or
yes,
yeah.
A brief reply,
Yeah, no problem. Blackpool is still going to be an acute stroke centre. The only where they will receive and look after their patients in the acute stroke centres, that is still going to be a hub, but the main hub will be Preston for thrombectomy. Now they've always gone there for thrombectomy. We just need more patients to go there for thrombectomy. So Blackpool is still an acute stroke centre and has been invested, and they're actually developing that service there currently.
Anybody else want to contribute? Councillor Lewis.
Sorry, I do want it not captured that there's still concerns about the travel aspect. I'm not concerned about specialist centres and people driving past RLI. I'm concerned that there are days where you can't get to where you're going, and that applies not only in Cumbria but in North Lancashire as well, because there would be days you couldn't get either direction to Furness or to Preston. So I'd still like that noted. I do recognise that you've indicated that there's further work planned there. Yes,
I would ask you yourself or Councillor Collins about Lancashire. Lancashire City Council covers quite a big area, isn't it? It goes quite a long way of the M6.
yes, all the way to Cumbria.
Yeah, I'm quite sure where Cumbria starts. Somebody from the south.
Yeah.
So,
Well, and I guess that's why the Bay Unitary was an excellent bid.
in fact, I remember having a caravan at one time, many years ago, Cape of Rain. So I explored the area. And the daughter of Lancaster University. Just on one of the issues we raised, the travelling time, and that's something I think we need to make representation at the end as a recommendation. Overall, the actual improvement in services we should see in the results. Are we happy with that? Councillor Ian.
Very happy with that, and it wonders why, you wonder why it hasn't happened sooner. We've been short of staff for years and years and years, haven't had the staff that's recommended nationally. So I'm still deeply concerned that they will get the staff in time to roll this out. Very concerned.
We can perhaps monitor that or come to some arrangement, I think. But the basic plan, I think, is absolutely sound. It's been implemented elsewhere. I think it's in Greater Manchester. So are we all happy or not? Sorry.
Gap in consultation with unions and professional bodies.
I'm just trying to get whether we're happy with it and whether we consider it, whether we don't consider it substantial variation. I do know that Cumbria, Blackpool and Blackburn have all said that they don't consider it substantial variation. So I'd like to, are we happy to agree that we don't consider it a substantial variation, given the sort of information we've received on the agenda pack? Right. Or any members think that it is? And there is implications if we do. Councillor Mead.
Yeah, I was just going to ask what the implications are. What difference does it make whether we consider it a substantial variation or not?
It is detailed in the papers. We would have to go back to the NHS and discuss with them about a possible public consultation and see if we can reach agreement. Probably the steering group. There is the potential for delaying things. If we can't reach agreement, then we can look at whether we want to refer to the Secretary of State.
Can I just come back to them? Personally, I wouldn't want to delay it. I think it's long overdue. So if calling it a substantial variation would delay it, then I'd rather not.
Councillor Lewis.
Thank you, Mr. Chairman. I am keenly aware of how anxious Lancaster residents are about changes in health service delivery and travel times, as I think is probably indicated through both mine and Councillor Colledge's comments. I think it is a substantial variation according to the very helpful tick sheet. But I guess, like Councillor Mean, I don't necessarily want to unduly delay, and I don't know whether any surety can be offered in terms of what further engagement there will be with members of the public. I know there's been constant engagement with survivors, stroke survivors, but more broadly, and whether if we at this point agree there is no substantial, that it isn't a substantial variation, whether that has any impact on the emphasis that will be given to resolving the transport issue. Thank you.
I have the feeling that Gary's going to tell me something. He's getting agitated on the seat. Councillor Dowding, then Councillor Pope.
Morning, Chair. Thank you. So yeah, this is a balance here because I'm acutely aware that we don't want to hold things up as being said. In the note that we were given about what constitutes a substantial variation and the characteristics, one of the points, it says under the column likely to diminish, defining this proposal as substantial, is a full assessment of the impact of the proposed change and mitigation included in the plans. And I just wonder, so maybe we could just have feedback again from the team on their rationale as to why this might not be a substantial variation, to help us with this decision, please.
I don't think that's a appropriate question to put to our visitors. That's something for us to decide.
Okay.
So defined definition of it is this the guidance we have. We would take it back if this committee voted for it today. We would take it back to the steering group for consideration. Councillor Poe.
Thank you. Yeah, clearly this is going to benefit patients right across the whole area, and I'm in support of it and would not want to see any delay on it. But I would like the steering group to maybe come back to us and give us additional information, particularly about the transport scenario. You know, people have got to be able to get to this, to these treatments, and I'm not sure that, you know, the discussions with the ambulance service, bear in mind that the air ambulance service is funded voluntary as to how they will cover the costs of the ambulance service going forward. So I'd just like some reassurance from the steering group on that the work has been done to quantify it. But I certainly wouldn't want to delay the process for too long.
Those are my views. Exactly. I mean, I'm hoping that the committee, and it's those present in the room who get to vote. Unfortunately, those who are attending virtually don't, can agree that it's not a substantial variation. And then we move on to giving feedback to the NHS on the question of ambulance travel time and consultation with the unions. I think Councillor Lewis mentioned, and then anything else. But that's where I'd like to take it forward now.
Sorry, Mr. Chairman, I think there are a number of hands up on the screen behind you, including Councillor Collins and can't read the other one. I thought Councillor Dowding's query was actually question was actually quite useful in terms of, because I'm sure our colleagues at the NHS must be aware that this is the test we're applying. So I thought their comments on why they think it isn't a substantial variation might actually be quite edifying. And I guess the thing I'm trying to understand is I know that the ambition is that that service for everybody will be improved. I can't help but think that at the moment, people in North Lancashire and South Cumbria might, well, this is what I'm not clear on. I'm not clear on what the change is in the patient journey for those people who live in North Lancashire and South Cumbria. I realise that maybe below the papers properly, but if somebody could indulge me, because I'm probably not moving until I'm confident that everybody getting a better patient journey includes North Lancashire and South Cumbria. Thank you.
It's on that. I mean, South Cumbria, the Cumbria County Council, the Health Scrutiny Committee, have decided that it's not a substantial variation. They're the ones who are responsible for the residents of South Cumbria.
I think my colleagues in South Cumbria would tell you that one of the reasons they wanted to leave Cumbria County Council was in fact that it was generally Carlisle focused and looks.
Let's not get into that in your promotion of that idea.
No, I'm not trying to push the idea. I'm just trying to say that many residents of South Cumbria don't feel that the Cumbria County Council focuses on their needs. They feel that it is focused on the north of the county, and that might be an answer to your question as to why we seem to have more concern than others have expressed.
I'll take Councillor Collins.
Thanks, Chair. I think
You're very faint.
Pardon?
Sit a little closer to the computer. Microphone.
Is that any better?
Yes.
Okay. I think Councillor Lewis makes some very good points. I know I don't get to vote today because I'm remote, but for the benefit of my colleagues in the room, I think on balance, taking into account the considerations, characteristics like defining proposals as substantial, that the committee should agree that it's not a substantial variation, but that we get strong reassurance that this will not disappear off our radars, particularly with the steering group, but also for the full committee if they wish, and that all the concerns we've raised will be taken forward seriously. But if I were in the room, I would be saying that that we should not consider it a substantial variation. Thanks, Chair.
Thank you for that. I mean, Councillor Pope, and I've agreed with it. Yeah, as well, we're quite happy to look at it as a steering group. You have spoken, Councillor Pope. I'll let you speak again briefly.
Okay, I mean, just going down the criteria, if you look down the right-hand side and go through the different issues as to whether it's substantial or not, basically, you know, clinically, the case has been made very clearly. We've got examples from London, Manchester, other parts of the country, that this works in terms of improving the care.
Councillor Pope, you're not going to be brief if you're going to go through the whole.
Well, I'm not going to go through. Basically, what I'm saying is that if you go through the different factors on the right-hand side of the list that we've been given, I think they are pretty much okay, and it's not a substantial variation. However, I think we need to keep it online with the steering group in terms of the reassurance from the team. Thank you.
Chair, I think we've discussed this for quite considerable.
Please.
We've been discussing this for considerable time. I think we're in progress, and the suggestion from Councillor Pope is a sound one, that there are concerns about traumatising the re-examine. We don't see it as a substantial variation. Well, I think most people in the room are of the opinion we don't want to delay the process. We do need some assurances about trading issue and travel time. I think we're all in agreement.
Thank you for that. Do I need to go to a vote, or are we all in agreement that it's not a substantial variation? We are. That's agreed. Now, which brings on to the second point. I think bring it back to the steering group meeting, got one next week. Next week, and we'll look at that, and then make contact with the NHS over those issues we've raised. So those issues are, and that's what we've got the ambulance, the travelling time, particularly from North Lancashire and Cumbria, South Cumbria. We've got consultation with the trade union, trade unions. What's the other ones? Vacancies, staffing, recruitment, that one. I think those are the three issues, weren't they? And I think, while we agreed it's not a substantial variation, we want reassurances that there is time to address those. It's been seen plans to address those issues. And time is going on today. Are we happy with that at present? Thank you. So that's agreed. So I'll close that item. Thank you all for that. Thank you for those who've come and given us the presentations. Very informative. And we'll be in touch shortly if that's right.
Many thanks, Chair.
Thank you.
Thank you, Chair.
Right, we'll come on to item 5. That's item 4, sorry. It's the, no, it's just item 5. It's an update on the housing and support strategy. And we have present with us we have Sarah McCarthy, Policy and Information and Commissioning. And then we have Dawn Aston. And Michael Sops online. And you're going to talk to us about Enhancement.
Morning. Yeah, I'm Sarah. Good morning. I'm Sarah McCarthy. I'm Senior Commissioning Manager, and
I'm Dawn Aston. I'm a Service Manager for Learning Disability and Autism Service.
Yeah, so we're here to give you an update on the housing care support strategy. I think you last had a presentation about this approach in 2019. We're going to split it. I lead the extra care element of it along with Mike Alsop, who is joining us virtually. And Dawn leads the services for working age adults with disabilities. So I'm going to start with the overview of the progress that we're making in extra care. And we're really pleased that we're joined today by Diane Emerson from Regenda Homes. She's the supported housing manager there. And we've also, and we're really pleased that 2 of the tenants from Lighthouse View have agreed to join and to give their views about how they how they feel about living within extra care and what it does for them. So we've got Mrs. Lineker and Miss Collier, who will be joining us later. Well, they've joined us here, and will be giving their views later. So if we start with the sort of overview of it, Gary, you okay to?
move through a couple of slides. Just the next one, yeah. So extra care housing. It's a specialist form of housing with care. And what we're seeking to achieve with this type of provision is to enable people to carry on living there for as long as possible. And because of the way that the buildings are designed and the way that the care has been delivered, the idea is that those schemes should be able to respond to changing needs. So they're self-contained flats with lots of communal areas and 24-hour care. I'm sure that Diane and the other people joining us from Lighthouse View will tell us a bit more about that. And I think what's really important is that we want extra care to be both a community itself, but also very much to be linked into the local area and to be part of that wider geographical locality as well. So moving on now to the objectives and strategy. So in terms of extra care, what we were achieving to do by 2025 is to have at least one extra care scheme in each district and to have 1,000 units. That's 1,000 flats. So to date, we've got 3 new schemes that have opened in the last couple of years, which are Lighthouse View, which we're obviously going to hear about, the Courtyards, which is a scheme in Preston, which is owned by Community Gateway, and also Primrose Gardens in Chorley, which is owned by Chorley Council. In terms of the current total amount of provision, sorry, back Gary. Back another one. So in terms of the total provision at the moment, we've got these 3 new schemes. We've also got 2 purpose-built schemes that were built about 10 years ago. One in Ormskirk, which is Brookside, and one in Whitworth, which is Greenbrook. Plus we have 8 sheltered housing schemes, which are combined shelter provision and extra care provision. So they're obviously a bit different in terms of the fact that the buildings were constructed in the 60s, so they're much smaller, less communal facilities. However, they do deliver a 24-hour, they have 24-hour care on site, so do provide a very important service. In terms of new developments, we have 14 which are either under discussion or under development, and I'll come on to them, give you a bit more information later. Just the other 2 sort of key points in terms of the development, we have a need to, so we, in the report that you were sent for the meeting, you would have seen that the actual need for services is slightly higher than the target. So the need is just over 2,000 units, but we'd a target of 1,000 by 2025. And that was because we felt we needed to make the target realistic, and we wanted to better understand demand and to learn from the experience of the first set of schemes that were developed. Now that target was based on a national benchmark. Oh, sorry, the needs was based on a national benchmark. We also have a sort of bottom-up approach to needs assessment, and we have a tool which brings together data, a range of different data sets by ward, and then ranks wards within a district to identify the areas that would appear to have the greatest need for extra care provision. The last point before we leave this slide is that Cabinet have said that at the moment there isn't a pot of capital for extra care. However, there would be consideration for giving land at a lower rate, or if that was needed to make the scheme stack up financially. Okay, go on. Yeah, so this slide just gives 3 schemes. So that's Primrose Gardens at the top, Lighthouse View in the middle, and at the bottom is the Courtyards in Preston. So we keep going. Yeah, so this table tries to summarise the developments and discussions that are taking place. Some of these are still commercially sensitive, and that's why we've not given the actual land and haven't given more detail. They are all at different stages, so some are much more progressed much further, others are early, very sort of early on discussion. So the ones that are the most advanced are the Burnley Hospital site, which has been developed by Calico, and there's a diagram in the next slide which we'll come to. We've also got Tatton Gardens in Chorley, which is another one being developed by Chorley Council, and that is due to open. It's now October. It slipped a couple of months since we did the slides. The ones in Fylde are still a much earlier discussion, so we can't go into detail about those today. Then there's the University of Cumbria scheme, which that has got planning approval, but that's still subject to approval funding. And then there's discussions happening in Pendle and Nelson. Another scheme being considered, built by Community Gateway in Preston. Early discussions in Ribble Valley and Rosendale. South Ribble, there's the West Paddock site, and West Lancashire in Skelmersdale, there's the Tobian site, which is subject to both planning and funding. And then we're also, once the residential care scheme at Garstang has been provided on the site, then we'll be demolishing the existing residential care scheme and building a new extra care one, next care scheme there, which would give Wyre their second scheme. So that's the current position with the schemes that are under development. Right. So this is just a plan of the scheme in Burnley. So it's a large scheme, 90 units. Planning application has been submitted by Calico. So we're really looking forward to that moving forward. And certainly my colleague Mike has done a lot involvement in the steering group for that project. One of the things that we are very mindful of is about how we allocate schemes and how we promote them. And it's very important that the landlords, care providers, social care all work really closely together. So we have developed panels for each of the existing scheme, and we're looking at also generally improving the referral pathways, because it's also mentioned on the slide that we are consulting with landlords, district council, social care and providers about the sort of lessons learned from the 3 new schemes, because obviously we want to make sure that we don't repeat any problems and that we learn and what's best practice. So that work is being undertaken as well. We also recognise that in terms of bringing more schemes forward, and it's the partnership approach is absolutely key, and that is how we will deliver more units for people in Lancashire. So we are looking at how we can work more closely with district councils to bring forward schemes more quickly, and to work jointly on these shared agenda. So we've just put in some quotes here from the tenants at Primrose Gardens and the courtyards. I won't go through them all. You've got them in your slides. But obviously that's what we're all here for. The most important thing is how people who are living in the schemes feel about them, and that the schemes are delivering what they want, and that the outcomes and the impact is what we are all focusing on. That's the thing that matters most. So that gives you the feedback from those 2 schemes on this slide. And then that takes us really onto hearing a bit more about Lighthouse View from Regenda. So Diane, can I pass over to you just to say a few words about the scheme?
Okay, thank you, Sarah, and thank you for asking me to talk about Lighthouse View today. I will keep it brief because I'm, conscious of time, because I could talk about Lighthouse View all day. I'm really proud of the scheme and the impact that it's had on not only the individuals that live there, but the community as a whole. We opened in November 2020. Don't make life easy. We opened during a pandemic. We have 72 apartments at the scheme, and we have a real sense of a community at the scheme. It's from developing the scheme for the last 6 years. I've seen some amazing outcomes for individuals that live at the scheme, and I'm so proud of the staff that work there and how the scheme is running. We've had some really brilliant feedback from tenants who have been on the journey with me as well, that have been on waiting lists for a long time, and the development of the scheme has proven really beneficial to lots of people. We've got at the service, we have a spa facility, a treatment room, and we have on-site local business that delivers spa treatments at the scheme. We have a hair salon with a local hairdresser that works at the scheme as well. There's an outdoor gym, and we have on-site care provision as well, which has also created approximately 18 local jobs for local people working in the area. The bistro is due to open mid-February. We've done things on a very slow and phased approach due to the pandemic, and it took approximately 4.5 months to fill the scheme of 72 units, which we did on a slow phased approach due to the pandemic. I'm going to pass over now to Katie, who is on site with our 2 lovely tenants who can tell you all about what it's like living at Lighthouse View. So I'll pass over to Katie now. Thank you.
Hi guys, I'm Katie, the scheme manager at Lighthouse View, and I'm here with 2 of our residents. So we've got Mavis and we've got Julie. So we've brought them here today just to give you an idea of what it's like to be living at Lighthouse View. So we're just going to pass across to them really, just seeing how you find Lighthouse View.
I think it's wonderful. It's just like living with your family. I think we've been very, very fortunate. The staff, the residents, the whole thing is for our benefit, and we just can't thank them enough. I'm sorry about my voice, but
don't worry.
I'm not going to sing for you. We are very, very lucky in so much as anything we want, we only have to ask, and if it was at all possible, we get it. We get help every single minute of the day, and it's a wonderful atmosphere. I recommend it to anybody. I don't even feel like an old lady living on my own because I've got a family here, and it's wonderful. Thank you, Katie.
And do you feel like from where you were living to here, you feel secure in extra care, it brings you benefits?
Everything, that was the main point. The extra care was the draw.
Yeah.
That I left my other little place, and I've never been sorry.
No.
Because the extra care's there all the time.
Yeah.
24/7. 24/7. I nearly got that wrong. And I love every minute of it. I really, really do recommend to anybody on their own who's lonely. And you never feel lonely again. I can assure you won't. Just come to Regenda.
Julie, how have you found it?
I absolutely love it here. I'd have done it years ago if I'd known how well looked after we are. Katie, Diane, the cleaners, it's an absolutely fabulous place to live. As you say, we're like a family. We all get on together, every one of us. There's no hard feelings with anybody. We can ask anybody for anything, and we all help each other. And we all do get together sometimes and have bingo and other games, quizzes, and it's just fantastic to live here.
Thank you. Thank you, guys.
Thanks, Katie.
Diane.
Yeah, hi Mavis. Thank you for your feedback. Lovely. Thank you.
I'd just like to thank you both for your thoughts on where you now live, your current home. We do appreciate it.
Yeah, absolutely love it.
Oh,
Thank
you're
you.
welcome. Thank you very much.
Right. Have we any more to come on the presentation?
Hey, I'm going to talk to you about supported living. Okay. So just expanding on Sarah's previous discussion on the care and support strategy, which was launched in 2018. Myself and a colleague, David Lovelady, were recruited to look particularly at supported living for working age adults. So this is supported accommodation, which offers independent living, care and support for people with a learning or physical disability. Next slide, please. So we've been developing a range of new apartment and bungalow settings, and these are replacing some of the traditional shared living properties. Each new setting will offer individuals their own front door, choice of furniture and access to communal areas, and opportunities to live as part of a community whilst maintaining a degree of independence. So progress to date is that we have delivered 106 new homes. We have 89 new homes in the pipeline for completion this year. We've retired 21 properties. You may have heard the word decommissioning in previous documents, but following feedback from colleagues and customers, we've decided that decommission isn't the best word. So we have handed back 21 unsuitable properties to landlords over the last 2 years. We've achieved £1.3 million worth of savings and developed an effective referral pathway to increase awareness of the offer to social care staff and ensure that the right decisions are made for the people living in these new homes. Next slide, please. I won't go through the full list, but just to give you a flavour of some of the new developments that we have delivered. As you can see from the slide, there's a range of different types of accommodation, including apartment schemes, shared houses and bungalow settings, as we've found that not one kind of housing does meet everybody's needs. When we were looking at retiring some of the properties we've handed back, it was made quite clear that some of the customers living there were older and needed level access accommodation. So we've developed settings to meet individuals' needs and a range of settings across the 12 districts. Next slide, please. So over the coming 12 months, you'll see we continue to develop a number of properties over the districts, including Leyland. We're looking at 7 apartments and a bungalow. Parkinson House in Preston, which is a new development of 6 apartments. Been tirelessly working in the Lancaster area for the last 2.5 years to develop accommodation. It's been an area that's proved particularly challenging. And we've got 2 new settings coming up in that area this year, which include Slime Road in Lancaster and Cumberland Court in Lancaster. And you'll see from the picture, anybody that lives in Lancaster may recognise Slime Road. It was formerly a Victorian police station and more recently an NHS building. This will deliver much needed accommodation in the area with some physically some accessible accommodation for people with physical disabilities. Alongside Sarah's development at University of Cumbria, we're hoping to develop 12 apartments in the same complex. And at the bottom of the page, you'll see we're also developing a shared property for 4 young people in Burma. Next slide, please. Okay, so my colleague David is working on quite an innovative approach of a good neighbour scheme. So this will offer subsidised rents in exchange for informal support. We're hoping to attract good neighbours from various sources, which may include LCC staff, local universities, etc. So this could be a student nurse or a social worker who's got an interest in working with people with learning disability, autism or mental health. And part of the task that they will undertake will be to ensure that they keep a check on neighbours and ensure that they're well, develop friendships, help out with small tasks such as shopping, changing a light bulb. If somebody's unwell, helping them to walk the dog or taking a walk with somebody. One of the big things that we've, that's come apparent over the pandemic is that people may need assistance in accessing new technology, such as using Zoom or accessing online shopping. And of course, helping out in an emergency situation, such as a water leak, severe weather or evacuation due to a fire. Next slide, please. So just to give you a little more detail on some of the developments, as I mentioned earlier, Slime Road is currently being developed. Planning consent was granted some months ago now, and contractors are now on site. We're expecting handover in August this year. Just to highlight, there were some planning delays due to COVID. Next slide, please. And the second development in Lancaster is Cumberland Court. This is development with also with Halo, and the anticipated handover date for this is March 2022. This was more of a refurbishment than a build, so it was an existing building. It's a smaller scale setting. We'll have 4 apartments, however, it will cater for 6 individuals. 2 ground floor apartments and 2 upper floor apartments for 2 people. So on this slide, you'll see Keith. Keith moved into Florence Avenue earlier in the year. Keith lived in one of the properties that we've retired. Keith and his co-tenants were finding living in a house more challenging because of physical needs changing. And they all now live next door to each other at Florence Avenue, so they still keep close and in contact. However, they've all got their own individual bungalows and front doors. Keith particularly is proud of his bungalow, and he's really enjoying having a garden that he can look after. And I believe he also helps his previous co-tenants out with their gardens, because it's an area that he really enjoys. Next slide, please. So my colleague David developed Orchard Road in St Anne's. This is a really beautiful development above some retail establishments. It offers people a real opportunity to be part of their community. There's a bistro downstairs, there's a Help the Aged charity shop, so people are really integrated into the community there. And there are a couple of quotes on there. One of them, this new flat has allowed me to live how I've always wanted. It's a really powerful statement from somebody that has moved into this new development. And the next slide again are some quotes from staff. It's been a pleasure to be here from the beginning, to see the project unfold into such a positive and welcoming environment. The people we support to live here are a pleasure to be around and have settled into their new homes with such enthusiasm and dedication to making their flats person-centred and homely. So some of the added value and benefits for people living in supported accommodation include increased independence, less restrictive living, having their own space, front door, be able to choose their own decoration and furniture, and just increased choice in how they choose to live, making new friendships and living in the heart of the community with much greater access to social activities and opportunities for volunteering and employment. Okay, so this is a summary from myself and Sarah and our colleagues. We've seen some fantastic progress over the last few years despite the pandemic. However, this has highlighted the need for much more flexible housing options for older people and working age adults with a disability. We feel Lancashire has great ambition and some very interested and willing developers and registered provider whom we've developed some good working relationships with alongside Homes England. However, some challenges do exist, not just in Lancashire. We've seen that development costs are significantly higher than in previous years. Some developers are withdrawing interest due to figures simply not stacking up for them. And the availability of land is a key constraint. As I mentioned earlier, you know, since I came in post some 2.5 years ago, some areas of Lancashire are proving particularly challenging, including West and North Lancashire. West Lancs, we're still working really hard to identify available land and developments at a reasonable cost. We are experiencing, alongside others, a lack of workforce across the whole health and social care sector, and this is impacting on extra care and supported living settings. An increase in demand for assessments and an increase in complexity of need is causing some delays in identifying suitable and appropriate settings for some. And emerging issues are coming through around fire safety, which is obviously a national issue, and we're consequently working with providers to look at individual properties on a case-by-case basis. Thank you. Next slide, we're open for questions.
Thank you for the presentation. Yes, I was on the cabinet at West Lancs when we opened the food site. Went through tremendous success. Similar stories to the two ladies in this photos. And in fact, one of the caretakers receptionist at West Lancs Borough Council actually lives in questions? Yes, Councillor Oakes.
Yeah, thank you for the presentation. There's some really good schemes there, I think, and I'm very pleased to see that Rossendale is making progress, shall we say, because I think it's a facility we really need in Rossendale, as everywhere. Could you just clarify the costs of them and how, I presume it's means tested, and the extra care, is it, I mean, what sort of cost are people paying for this facility?
In terms of supported living, people receive housing benefit to pay for the rental aspects of their accommodation, but their package of support will be met through Lancashire County Council. Each individual will be assessed financially, and various contributions will be made depending on their income. We're probably looking around £200, £250 a week rent for most apartment schemes at the moment on average, which is pretty consistent with specialist accommodation. There is some variation. Myself and my colleague David are working very closely with registered local providers, established providers such as Calico, Progress and Halo, to ensure that the developments we are looking at are more cost effective, both for us at Lancashire County Council and our district colleagues who foot the bill for housing benefit.
Yeah, thanks for that. It's just a bit concerning when you see, and I totally understand it, development costs are significantly higher than a year ago. So, you know, I just worry that facility is going to be out of price range for quite a lot of people very soon.
It is an ongoing concern, and we are having conversations with Homes England about rising costs. It's a national issue at the moment.
Right, I've got now County Councillor Collins.
Thank you, Chair. Try and keep my microphone close. So my first question, you'll be unsurprised to hear I've got a few. My first question is about the square footage of the properties. So looking at some of the illustrations, for example, of the bungalows, they called to mind the little council properties that in my family are called swinger cat houses because you can't swing a cat in them. and I was wondering what the square footages of both the apartments and the bungalows are, and how they compare to, you know, standard private rental apartments, or indeed more standard social housing. I'd like to just hear a little bit more about the funding model, because I'm just not quite clear how they get paid to get built. It does seem to me that the providers who are actually running the schemes are not Lancashire County Council, that they are other bodies, whether that's private or you know, community interest companies. So I think I get, once it's up and running, I get how that funding works. It's more how they get built that I'm not really understanding. And the access route, you know, are they first come, first served? Is there waiting for access, as in, you know, people with a different financial situation, would they get a higher priority? And finally, I'm just wondering about the upkeep. They look absolutely beautiful, the schemes we've seen so far. I'm wondering how we ensure that they stay a really pleasant and nice environment for people to be in. Thank you.
In terms of supported living, we anticipate a minimum square metres of 45, on average 45 to 50. They are particularly spacious, quite significantly larger than your previous sort of ex-council house bungalows. I've worked in the sector for a number of years, and I completely appreciate where you're coming from in terms of your analogy of swinging a cat. So yeah, they are very spacious. We have specified minimum standards for all new developments. Sarah, do you want to comment on your extra care?
Yes, same as Don said, that the extra care apartments are much larger. We've actually got a number of 2 bedrooms as well within the scheme. So I think that people are very sort of pleasantly surprised really about the size of the provision. I don't know, Diane, do you want to add anything from Lighthouse View about the size?
Yeah, we have a range. We have like lots of different apartments, and they are really big. We've got 13 2-bed apartments, and they do offer a lot of space within the apartments. Even the 1-bedrooms are large. You know, there's a good footprint there. And to give you the sizes, I don't know top of my head, because we've got that many different design of properties, but they all met, you know, the standard sizes for disabilities as well. So that was all taken into account. And in relation to the funding, pre-build, Homes England was the funder for Lighthouse View. I'm trying to think about, the other question about the upkeep as part of the service standards that we deliver across our services. Everything is obviously quality monitored, and we ensure that we have, as part of our budgeting and forward planning, is the 10-year plan of replacements as well. So to make sure that the properties are kept to how they should be kept as well. So I think was that all of the questions?
I can answer your question about the allocations.
Oh yeah, the allocations as well. Yeah, sorry.
So in terms of extra care, we've got a pretty much a common allocations policy across all of the new extra care schemes, where there are 3 priority groups. First priority would be people who would otherwise be in residential care, or we wanted to do on from residential care if that's no longer needed. Second priority are for people who have got an eligible care need under the Care Act. Now that could be both people who have got a commission care package, but also people who have opted to have informal care, because we want to support that. And then the third priority would be for people who don't actually have an eligible care need under the Care Act, but would benefit from living in an extra care environment. So we try to, I think Dan confirmed that we try to have some level of a mix, some level of, we want a sort of vibrant community, but equally we want to make sure that nobody, that we can move towards people not having to go into residential care if there's, you know, if there's an extra care unit available. So that's why we would always want to try to prioritise people to keep them in an independent tenancy as much as possible.
Okay, thank you. Just to clarify then, the allocations are done on essentially the basis of need using those priorities. Okay, but are agnostic as to funding stream.
Yeah.
Is that right? Okay, thank you.
And sorry, the other thing I should have mentioned is that we have panels, so we make sure that the landlord, the care provider, social care are all involved in that decision, and we, you know, look at the risk, look at the level of need and vulnerability, and work together to make sure that it's right for the individual.
Okay, thank you.
Right, and now I've got 4 more questions. 5 more questions, that's it. That'd be too late. The brevity is required. Councillor Julie Robinson.
Thank you, Chair. Obviously, I'm the Wyre Council, and I was looking on the estimated number of units needed. It's very high in Wyre because it says it's 265. I know Beaugrave, we've got 1 development. Is that going to be the same stamp as the Lighthouse View, or what is that going to be? Even when we've had that, we're still 193 short. What's been identified for Wyre and the needs? Is it supported living? Can you tell me this, please?
So we're currently working on a development in Garstang, which will be 9 apartments. However, that will likely be 2023. So that developer is just currently going for planning permission. In terms of extra care, Sarah indicated earlier, Beaugrave Rise will be an extra care scheme once current residential setting is demolished. So we'll go into more detail with Sarah.
I think that what we're wanting to do is to obviously look after new schemes have been developed is to look at the demand. So one of the things that we would now be doing is looking at the demand for Lighthouse View and working out about that. Well, I think will help us look at what else is needed within Wyre, and we'll be working with Wyre Council and landlords to look at that sort of the next steps for the district, which is our approach generally.
Okay, yeah, because I just thought it seems quite high, even when we've knocked that one off as the areas. It's like you say, still a demand there, still a demand needed. But thank you for that information.
Next question is from Councillor Pate.
Thank you. I was really pleased to see the happy residents in the houses on Florence Avenue, because that is obviously in my division, and it's a really positive development in the area, as well as being positive for the people who are living in there. I'd like to ask 2 different questions. So one is on supported living and the other is on extra care. So supported living first. There was discussion there about housing benefit. I'm just wondering, is this open to people as well who are actually working but have additional needs and therefore may not qualify for housing benefit? And if so, is that rate of rent going to be at an affordable rate for those people? And the other question on that was, is there a need for accessible housing as well as supported housing? I don't know if there is a need. I'm asking if you've identified any needs, and if you have identified a need for accessible housing, how that's being addressed. So on to the extra care. There are 90 beds currently being built in Burnley up at the hospital. How far does that go to addressing the need? Because it's quite a considerable number to come from 0 to 90. I know there was a former site there that was identified, a former LCC school site that never came to fruition, but this is a really positive move. How far does it go to addressing that need? And when will we be able to find out more details about the other site that is going to be considered within Burnley, and how many beds are within that? Thank you very much.
I think so, yeah. Right. So in terms of affordability, as I mentioned earlier, my colleague David and I are working very closely with providers to ensure that new developments are more affordable. Specialist supported housing is notoriously higher levels of rent than other sectors of the rented market. The district councils manage the housing benefit role. However, I am aware of individuals living in our supported housing who do work and volunteer and continue to do so. There are a number of housing benefit opportunities for people to take advantage of, including discretionary housing benefit, and people's benefits themselves do enable people with disabilities to undertake some element of work. I can get more information on that for you, but I don't have it to hand. It's not an area that I deal with directly myself. In terms of accessible accommodation, we're currently working very closely with colleagues across adult social care to undertake a needs assessment for people with physical disabilities and acquired brain injuries, because it's become quite apparent over the last 2.5 years since myself and David have been in post that there is a real shortage of accessible accommodation across all districts. Sarah and I and other colleagues have recently met with district colleagues to discuss this amongst other areas for consideration. Some people are in residential care purely because there is not accessible accommodation that meets their needs, which is obviously a significant issue for us.
In terms of extra care, the second site, we can't disclose the location at the moment, but it is a reasonably sized extra care scheme that's been proposed. Mike, I don't know if you want to add anything to the Calico scheme.
Yeah, yeah. So the Calico scheme's 90 units, so it is significant in terms of what we'd stated the need was in the strategy originally, 134. And I think the other scheme that was under discussion was around 60 units. So it would actually take us over there. But I think it's relevant to say that there's no exact science to predicting the numbers of people that you need. You'll see the figures that Sarah's used, which is like a standard, if you like, that's used across the country. But Sarah's right in that what we tend to do is we tend to look at where a particular scheme has gone up and what the demand looks like for that, and sort of, you know, taking it at that type of pace, because I think if you overdevelop, you don't want to end up with a scheme that isn't being utilised properly, and it's, you know, the needs aren't there for it. So there is a strategy here, I think, that's useful in terms of how we're looking at that. But we're not batting people away either where it meets the currently identified need. What you might find is in some areas you'll find that there's more extra care than you might get from a simple calculation that's in the strategy document. So yeah, and I think the Calico scheme at Burnley, you know, again, has got everything in it. It's there's a bistro being planned in there. There's community sort of rooms that are planned in there, and it's very similar to some of the others that you've seen and heard today. So yeah, I think it will go, you know, a good way towards meeting the need there in Burnley. I hope that answers the question.
Thank you.
Thank you. I've now got Councillor Ashworth.
Thank you, Chair. A couple of, I hope, very brief questions. One is about the social care, the actual provision of care in these units. I'm familiar with Greenbrook House in Whitworth, and it seems that there are a variety of care providers that go in the property. So I'm asking really, would this be one provider for the whole place, because that seems to be much more consistent and you can monitor the standards much more easily? And my second question is about the Good Neighbour schemes. Sounds a really good idea, but I'm just asking about the subsidised rents that you've mentioned. Would that mean that the person who was being the good neighbour would have to be eligible under the normal criteria to occupy one of those flats? Thank you.
So in terms of your first question, at Greenbrook, the tender for an on-site care and support provider and that organisation will deliver the 24-hour staff presence and any emergency response, background cover. Tenants are then able to either choose, if tenants have their own care package, they are able to choose whether to have the on-site provider or to opt to have a different provider. So obviously there's a lot of benefits in the on-site provider because it's the continuity of care and that generally encouraging. However, it's absolutely the right of the individual if they want to opt for a different provider to do so. But as much as possible, we try to promote the on-site.
Okay, thank you.
In terms of provision, sorry.
There's more to come.
Just going to clarify in terms of care provision in supported living, we would do a call off from our approved providers list. So 18 months ago, Lancashire undertook an exercise to appoint approved providers. We have over 50 providers on that list and it will be open for the next 10 years. So we're currently going through a process of business transition. So whereas providers are already in properties, we are transitioning their business over onto the new APL contract, and any new developments will be open to mini competition. So they will be fairly awarded, and a call off will be undertaken as per LCC procurement rules. There was a question about eligibility for Good Neighbours. The Good Neighbours will live rent free. The rent is paid in terms of their contribution as a good neighbour, so that they don't have to be eligible in terms of requiring social care. We would anticipate our good neighbours do not require social care, so that they are able to assist others living in the setting that do need some help and support. Hope that answers that question.
Thank you.
Right, I've got 3 more questions, and that definitely is. I've got one other business to go by. Councillor Mead. Councillor Lewis.
Thank you, Mr. Chairman, and thank you very much for the presentation. I represent Jonagall Ward in Lancaster City Council, which is where the ongoing discussion with the University of Cumbria is. So this is particularly of interest to our residents. Oh, sorry, I'm looking at my notes. Oh, yes, that's true, I can. That's an excellent suggestion. Thank you very much. Thank you. I'm very aware of the challenges in the social care workforce at the moment, and I wondered if you could speak to how this kind of change in provision impacts on workforce considerations. I guess I'm not sure whether it increases demand or decreases demand in terms of staffing. And in Jonagall Ward, we and Lancaster South East broadly, we have a number of remaining residential homes. There's a couple of large houses on Costa Road, and so I'm kind of wondering, is there an intention to retire those premises and move those residents to other places? And I'm somewhere in the report it notes that Lancashire County Council might contribute land to these proposals. And so I know that one of the conversations we have at Lancaster City Council is that if we contribute land to a project, we might want to retain some ongoing interest in that project. I think there's a lot of conversation at the moment about, given the fragility of the social care market, whether there is actually a need for there to be more public provision of social care services as a backup, as a way of influencing market provision and things like that.
Councillor Lewis, can we have a proper question?
Yes, the question's right here.
Discussion.
Question's right here. And so I'm wondering if this is a way for Lancashire County Council to return to providing more of its own social care. Thank you.
Okay, so in terms of staffing considerations, it won't necessarily mitigate the need for staffing, because people's social care needs vary, so their needs will need to be met. Apartment schemes and larger scale settings do offer an opportunity for some efficiencies in terms of background and night staff. So, for instance, you might have one member of staff covering an apartment scheme of 12 at night, whereas previously had four three-bed houses that all needed a member of staff at night. So it has, you know, efficiencies in terms of staffing and financially. In terms of some of the older properties you mentioned, no, we do not intend to retire those properties. We may move some people onto more suitable settings as their needs change over the years. However, in Lancaster, currently in the north, we cannot afford to lose any bed spaces effectively. We're currently working with Great Places who own those properties, and they're transferring that stock to Progress so that we can retain it and it will be invested in and be kept to a standard that we expect it to be. Question was, sorry. Yes, so we work very closely with colleagues at district. So I work very closely with Cathy Beaton at Lancaster. We meet regularly to discuss opportunities for land and also look within Lancashire County Council's assets. Unfortunately, haven't discovered any gems that we can take advantage of. But in terms of, as you were saying, local provision, we're working very closely with Lancaster City Housing. They're really keen to work with us to develop supported living. So we'll continue to work with them. We're currently working on our first ever supported living house with them. They're keen to work with us in the future. So I'm really positive about that. And as we said earlier, we are meeting regularly with districts to try and develop those relationships and see where that could benefit us in this aspiration.
Finally, Councillor Jones.
Thank you. I just wanted to ask, similar to what Councillor Lewis was saying, obviously we have a lot of care home stock, and obviously there's many in our division, and they don't have as much street in St Anne's. You need 1,000 more homes. What is the referral process? And if somebody has, for example, direct payments from the county council has a care package, does that take it, because it's obviously for respite and other things, does that take into consideration if they move from where they currently are into one of your places?
So whether people receive direct payments or individual support funding or the contracted payments is irrelevant. That's not considered at the point of referral. We would consider their need. That's the priority. So we have a referral pathway that I mentioned earlier. We meet on a weekly basis and we have a range of practitioners on there, including myself and my colleague, local staff and social workers present their case. We also hold a waiting list, so we have got people currently who need accommodation. We haven't got anything available, but we keep hold of that information and regularly refer to that list when vacancies come up, so that we're equitable. We are also looking at need. So, for example, I mentioned earlier that we're developing a shared house in Burnley for 4 young people. It was identified that those individuals couldn't live in an apartment setting. So we are developing the appropriate housing to meet their needs. So where social workers bring to us maybe a list of individuals that could share a property and that's deemed appropriate, then that's what we will do. So, you know, we're very much looking at it on a needs basis by district, but also looking at it from an individual needs way as well.
That's the end of the group. Do appreciate all 4 of you coming. The report was for noting, though just mentioned actions identified as next steps. It's obviously a great deal of interest amongst the councillors. You're doing good work. I just think perhaps put in for 18 months so you see view progress again. And all bear it in mind, both here and other councillors. Awareness support can be opportunities. Thank you. We move on. Item 6 is the report of the Health Scrutiny Steering Group. I'm not going to go through that. Does anybody want to raise anything from it? There's a lot of information there and various links. Yes, councillors.
I think this is the right paper it was on. One of these many papers mentions working with district councillors, which I thought was very.
Sorry, you speak
sorry,
high.
speaking to the
bring
microphone.
Bring it a bit close to you, I can hear.
Yep, sorry.
I am getting on, you know.
Sorry, I may be on the wrong paper, but no, here's my notes. I noticed that it says in Appendix A on page 118, it says request that the Internal Scrutiny Committee establishes necessary joint working arrangements with district councils and other neighbouring authorities. And despite the fact that I think I have now sat on internal scrutiny for 5 years, I'm not sure that we've ever made, other than the flooding task group, we've ever made a particular effort to reach out to district councillors. But I was very excited to see it there, and obviously the chairman has just mentioned it in terms of providing additional briefing for these schemes. I think given that everyone's very aware that there's a need for us to work more closely across the 2 tiers, I think it would be actually a really useful thing if this committee and other bodies thought about where briefings could usefully include both district and county councillors, and your program might be an excellent place to start. Thank you, Mr. Chairman.
Well, bear it in mind. But that's the time of committees. So yes, they're all interesting, and steering groups very interesting. But if you had all the presentations we had, this committee gone for about four hours. And it's just, and if we do find something particularly interesting, we do bring it to you. So that finishes item 6. You already asked to note it. Receive it. Item 7 is the Health Scrutiny Work Programme for the current year. It's one to be developed for the new year, which starts in April. Work to do on that. And we have had to do some juggling, some changing circumstances. We're trying to give you an interesting agenda. It's interesting today. Enjoy that one. That's for noting. No urgent business. Date of the next meeting is the 22nd of March. Thank you all for attending, both here and at home. Bye.
Thanks, Chair. Bye.